Neuromyelitis optica. Affects the optic nerve and spinal cord, sparing the brain. NMO is a condition where the immune system attacks the optic nerve and spinal cord but spares the brain. Neuromyelitis optica, NMO, also known as Devick's disease, is a rare autoimmune disorder where the immune system mistakenly attacks the central nervous system, specifically the optic nerves and spinal cord. Here are the key points. Symptoms: it often causes optic neuritis, inflammation of the optic nerve, leading to vision loss, and transverse myelitis, inflammation of the spinal cord, resulting in weakness, numbness, and sometimes paralysis. Diagnosis: diagnosis typically involves MRI scans, blood tests for specific antibodies, like AQP for IgG, and a thorough clinical evaluation. Treatment: while there is no cure, treatments focus on managing symptoms and preventing relapses. This can include immunosuppressive therapies, corticosteroids, and plasma exchange. Dystrophia myotonica. Key characterized by distal weakness, autosomal dominant inheritance, diabetes, and dysarthria. Dystrophia myotonica is a genetic disorder characterized by progressive muscle wasting and weakness. Here are some key points. Inheritance: it is an autosomal dominant condition, meaning a single copy of the altered gene in each cell is sufficient to cause the disorder. Symptoms: patients often experience distal muscle weakness, myotonia, delayed relaxation of muscles after contraction, and other systemic issues such as diabetes and dysarthria, difficulty speaking. Diagnosis: diagnosis is typically based on clinical examination, family history, and genetic testing. Management: there is no cure, but symptoms can be managed with physical therapy, medications, and supportive care. Anterior spinal artery thrombosis. Key causes: sudden paralysis and loss of pain and temperature sensation below the lesion. Cauda equina syndrome. Key lesion in L4, L5, or L5S1, leading to gait disturbance, saddle anesthesia, and loss of bowel and bladder function. Third nerve palsy. Key presence with LMN ptosis and a dilated pupil. Third nerve palsy, oculomotor nerve palsy, is a condition where the third cranial nerve, responsible for controlling most of the eye's movements, the eyelid, and pupil constriction, is damaged. Here's a detailed explanation. Key features: ptosis, drooping of the upper eyelid due to weakness in the levator palpebrae muscle. Dilated pupil, the pupil is abnormally large and does not constrict properly in response to light, indicating involvement of the parasympathetic fibers of the oculomotor nerve. Eye movement, limited movement of the eye, often resulting in double vision, diplopia. Causes: aneurysms, particularly of the posterior communicating artery. Tumors, brain tumors can compress the oculomotor nerve. Trauma, head injuries can damage the nerve. Ischemia, reduced blood flow, often due to conditions like diabetes or hypertension. Infections, certain infections can affect the nerve. Diagnosis: clinical examination, assessment of eye movements, pupil response, and eyelid position. Imaging, MRI or CT scans to identify structural causes like aneurysms or tumors. Blood tests to check for underlying conditions like diabetes. Treatment: addressing the underlying cause, for example, surgery for aneurysms or tumors. Symptom management, use of eye patches or prisms for double vision, and medications for pain. Rehabilitation, physical therapy to help with muscle strength and coordination. Horner syndrome. Key presence with ptosis and constricted pupils. Horner syndrome, also known as oculosympathetic palsy, is a neurological condition that affects one side of the face and eye. Here are the key points. Key clinical features. Ptosis, drooping of the upper eyelid. Miosis, constricted pupil that does not dilate properly in low light. Anhidrosis, reduced or absent sweating on the affected side of the face. Causes. Nerve damage. It results from damage to the sympathetic nerves that run from the brain to the face and eyes. This can be due to trauma, injury to the neck or chest. Tumors, such as those in the lung, Panco's tumor, or neck. Stroke, affecting the brainstem. Surgery, complications from surgical procedures in the neck or chest. Diagnosis. Clinical examination, observation of the characteristic symptoms. Imaging, MRI or CT scans to identify underlying causes like tumors or structural abnormalities. Pharmacological tests, using eye drops to observe changes in pupil size. Treatment. Addressing the underlying cause, treatment focuses on managing the underlying condition causing the syndrome. Symptom management. In some cases, no specific treatment is needed if the underlying cause is benign. Lower motor neuron (LMN) ptosis accompanied by a dilated pupil indicates a third nerve palsy, while ptosis with constricted pupils suggests Horner's syndrome.